Um, so welcome to the panel discussion on big data. First of all, I'd like perhaps if we could introduce ourselves from that end, please, just briefly.
So, good afternoon. I'm John Crawford. I'm IBM's healthcare industry leader, and I'm also the Vice President of the European Health Telematics Association.
Good afternoon, I'm Chris Roach. I'm the Chief Commercial Officer for Iridia Informatics.
Hi, I'm Chris Folk. I'm the Chief Clinical Information Officer in Hampshire Hospital NHS Foundation Trust, and I'm a registered nurse, and I do a lot of shop floor, sort of like direct care and transforming IT.
Hi, I'm Neil Speak. I'm a reader in the Health Informatics at the University of Manchester and at the Health E-Research Centre. And I was previously based in Amsterdam, came over to the UK last year. I'm also chairing an international working group from the International Medical Informatics Association, EMEA. That's a working group on data mining and big data analytics.
Hi, I'm Ian Buchan. I'm Professor of Public Health Informatics at the University of Manchester, where I lead the Centre for Health Informatics, Health E-Research Centre, and I'm one of the directors of the FAR Institute with responsibility for North England.
My name is Brendan Delaney. I'm Chair in Primary Care Research at King's College in London. I have a particular interest in the concept of the learning healthcare system. So the format for the next 40 minutes or so is I have four broad areas that we discussed earlier on this morning. I'm going to set up the panel to have a little discussion around each of these areas and then open it up to the floor for a couple of questions. So we'll cover iteratively backwards and forwards through there. I mean, the first question that came up this morning, certainly on our table, was the issue of validity. Not necessarily the obvious one on data quality and potential biased data, but actually the validity of methodology. We have a different paradigm between health science and data science. Maybe, Ian, I know this is something of your interest. Maybe you'd like to comment on that first, and then perhaps we can...
Certainly. Validity, the fitness for purpose of the analyses of the data. I often ask colleagues to reverse engineer the decision you're trying to take. So is the analysis and the data quality appropriate for the decision you're taking? Which is often different when you're trying to support a frontline decision to refining out a truth, say for epidemiology, for a scientific paper. But in all of those quests, whether it be health service or health science, there is an understanding that an awful lot of what we are trying to reason about is very hard to measure. So there's a lot of missingness, there's a lot of measurement error, there's a lot of indirectness. So much of the modeling thinking and practice cannot happen in the data alone. Yet much of the data science community work from the data containing all of the concepts that you are trying to model. So the metaphor of looking through a prism through a doily at the problem is often a useful way of explaining to people who've been teaching robots to walk around the room or looking at next generation web technologies purely from a data perspective, that the scarcest resource we have for producing valid support of decisions in healthcare is that human reasoning. So pushing on big sense making rather than big data.
So can we convince the skeptical health research community that analyses of large data sets can contribute to sensible data for healthcare?
Difficult to hear you at this end. Just repeat the question again.
Is it? Sorry. It's a bit of boomy, isn't it? Is it possible, do you think, to establish robustness of methodology and analytics using routine health data at large volume that will be at least approaching the convincing nature of the randomized controlled trial, the meta-analysis, and the robust epidemiological cohort study? Is it possible?
I think you could also turn this question around. So we tend to look at the randomized controlled clinical trial as the gold standard. Actually, if you speak to people who work in practice, particularly general practitioners, they will tell you that most of the evidence that comes from randomized controlled clinical trials is not very useful for them. For one thing, because often trials do not answer the questions that they have, and if they do that under such controlled environments and such selective populations that the answer is not representative for the type of patient that they see. So I think that studies based on routinely collected data, for instance in general practice, can add a lot of value to the evidence that we get from randomized controlled clinical trials. Now in both, there might be a little bias. So in both cases, we're probably not at the truth completely, but a little bit deviating from it. But they can complement each other a lot.
So looking at different aspects of the problem. Does anyone else? Yes.
I think from a clinical practice point of view, and I'm not an academic, so I'm really, as I said, I'm at the sharp end and at the front line. And the thing is, if you look at the validity of the data, is how do you collect that? So it's very, very good in regards to, okay, from a systems point of view, everyone will say, okay, well, as long as it's structured, we know what to do, we know how to code it, and it'll be valid and we can use it. But actually, clinical practice doesn't work like that. So for instance, as a nurse or as a doctor, I do a lot of data entry, but actually it's just free text, and it's rich text, very rich, it's full with information, but actually it's not in a structured method. And it's something that we've been thinking about quite a lot in our organization in regards to, well, should we not use that information or that data to make that more valid? So we've done a proof of concept in regards to, okay, if you actually use one of these analytics engines and actually extract that information that people use on a day-to-day basis, very quick, very rich, you can actually then structure it and look at it. And so, for instance, what the outcome was for us in this study was that actually 10% of comorbidities sit buried in a non-structured electronic handover tool and doesn't get referred to in a case study, in a case note. And I think that's quite important, and that's why we need to think about.
I think the other thing to think is think of something that Martin was talking about. If you look at the validity of what your data is today, then you're looking at it from today's paradigm. If you turn it around and say that may be more valuable in the future, but I just don't know that now, you'll collect and you'll store your data in a completely different way. You'll move from, I have to put it in this structure because that's what I want to solve today, to let me put it in more of a data lake structure, and then maybe something will become valid in the future. So the genome's a classic example of that. Yeah, we used to throw loads of that away, and now we collect it. So I think you've got to be careful about making things valid just for today, as opposed to, could this be useful at a future point in time?
Yeah, I'd like to pick up on that point. I really want to make 2 points. One is, when we went from paper medical records to electronic ones, we changed the medium, but we didn't change the purpose of them. The written medical records were always just notes to the doctor about the individual patient. We had the opportunity as we went electronic to say, no, they're actually about improving medical science, about improving healthcare, and that's one of their primary functions. And I've heard people say that we really shouldn't talk about secondary use of health data. It should all be primary use. You know, when you're keeping a record of what the patient's diagnosis and prognosis is, you should also be capturing the knowledge that you can then feed into the medical science process. The second thing I wanted to say is to do with quality of data. Obviously, clinical trials are widely accepted as being, you know, the gold standard for how to prove or disprove a hypothesis. But last year I was involved in several meetings which were looking at this whole question of real-world evidence and adaptive licensing of drugs. And in that situation, what I observed was that although the clinical trial gives you a very good idea as to whether a drug's going to work, you don't really know how well it's working until you start looking at the real data coming back from the patients after it's been licensed. And the reason why this is important to the pharma industry, of course, is they can take drugs that did not pass through traditional clinical trials and they can repurpose them for particular groups of patients for whom that drug is going to work based on real-world evidence coming back from from effectiveness as it's used day to day. So I think, you know, we need to kind of get beyond the idea that clinical trial method is the answer to everything. It's great, but the real-world evidence actually, I think, is a really equally important source of insight.
Isn't this something in Ian's area, the Salford Heart and Lung Study?
Absolutely.
Yeah, I think an important context for real-world evidence that patient groups often come back to us with when we discuss the production line of evidence and what that means for taking a decision. And the sum total of medical knowledge predicts about less than a third of the average response of the average patient to the average treatment. So there's a duty to surface even a small amount of that remaining 2/3 of natural experiments. Could lead to very large benefit, and I think will carry with it a large patient and public mandate to do so.
I think there's a very good comment. I mean, from my perspective, I'd quite like to subvert the big data agenda to really focus on those two issues. How do you generate fit-for-purpose electronic health record systems that are intelligent and able to support clinical care rather than simply being electronic paper? And secondly, how do you link this cascade of large and small, tightly controlled and more real-world learning cycles to support that process? I think that's exactly what the learning health system is, wider than big data. It's an agenda. I'll take a point there for a short break for questions or comments from the audience. In this area, in terms of data validity, analysis validity, standards of evidence, health records, does anyone want to step in at this point? Yes, please. And we'll bring a microphone to you. Gentleman at the table there with his hand raised. Just here. Yeah, who's first? So if you just briefly say who you are.
Hi, it's Owen Johnson, University of Leeds. Just a comment really on the question of clinical trials versus big data, and I think the point that the panel didn't make, but maybe want to explore, is the velocity of data in the big data world relative to the velocity of clinical trials, which can take, say, 5 to 6 years to get funding for and then do and then write up and publish. So I think the velocity might be a theme to explore. That's a comment, but I want to respond.
So in non-velocity, the point we haven't raised is the importance in the future of data from people in their daily lives. N-of-1 experimentation becoming very important, particularly personalising, tuning medication, also enhancing treatment experiences and engagement with services in proportionate to need. So the velocity of data, I think, will take a step change as we start to integrate patient-reported data from mobile technologies, sensors, etc.
One more? Yes. What's that?
My name is Akil from Community Software. I'm a health tech startup. But do you think that big data can really change the way we do science in terms of proof of hypotheses and stuff like that? Because right now, it's beautiful what you guys can do, but it's still not real, if that makes any sense. People are still not adopting those methods to do science. So do you think it can actually take that change, make that change?
Can big data do real science?
We're quickly going to end up in all kinds of philosophical angles here, probably. There's a very famous essay from a few years back, 2009, I think, saying that big data is the end of theory, the end of the need to have theory, because basically you can derive everything from data. Actually, I do not believe at all that that is true. And in that sense, I think that big data will not radically change science. There's still, as there's always been, there's going to be an interplay between theory and empirical science. What perhaps changes is the role of empirical science within that interplay, and obviously within big data, the emphasis is much more on the empirical side of things, and there are much more opportunities to investigate things empirically that we couldn't investigate previously.
So the truth is somewhere in between. Sorry. There's, I think in the Foreign Institute we've banned the term data-driven or hypothesis-driven, because the truth is that hypotheses are informed by quick looks at data, by structure in the data. There are an increasing number of discoveries that have been made not on a priori hypotheses, but on hypotheses raised by looking at the structure in the data. There is an inevitable interplay between the inductive and the deductive approach to reasoning around problems and questions alongside ever more data. So it's not either or hypothesis and data-driven. It's the blending of the two is the interesting bit.
So I'll look at this through a business lens and look at how personalized business models, which is where ultimately healthcare is going. If you map your genome, you're down to the ultimate personal business model and everybody is a customer of the health service. And if I look at other industries who have radically changed and transformed their industry, you look at all of them, mobile, retail, banking, all using the same premise that data is the way to radically do that, all driving personal business models, which is ultimately where healthcare is going. You have to make the assumption, that it will have a massive effect on that. So it's like the evidence is in other industries that what you can do with how you can change the business of that industry. So, if we say, I don't think that's going to be true, one of the big changes to make, and it links to the validity one, is we have educated ourselves around data that we have to structure it at the time we collect it. Yep. And what all of the other industries have done around data is they've waited to do late binding of the data structures now before they use the data. They haven't bought in, but for 40 years we have educated ourselves that we must build this common data model that will be the ultimate thing, the one ring that rules everything. And that shift, and if you look at the shift all those industries have made, they've decided that is not a data model or a data approach to move forward. We'll move to a different model. Now, healthcare hasn't really made that shift yet. So I think once that shift at the data fabric changes, then I think you'll see massive change moving forward.
Okay, interesting thought. Okay, well, I'd like to turn to our second area now. This is the question of silos, but not so much to start with the issues around data silos and interoperability, because I think that's kind of well visited. But what about commercial and business model silos? People seeing that they don't want to share data because they want to extract value out of it themselves. Maybe perhaps start with John and then move up to Chris. How can we solve this issue?
Well, I think this brings up the question of data ownership and who gets the benefit from the provision of data. I hear a lot of lawyers getting into big twisted debates about who owns the data, whose data is this. In many ways, it's not a very useful discussion because in a way, the data has more than one purpose. If the data is provided by you to your doctor to help you with care of you, then that's fine. But there should be other purposes, higher purposes beyond that which exist. And I think the question is really, how do you allow the data to be used for a variety of purposes, for which it perhaps wasn't originally intended, but for which the individual still consents? Because you're trading basically something about yourself to help your own condition, but also hopefully to help other people. When I look at European systems of healthcare, they're all grappling with this problem of data governance. To what extent does the individual have the right to withdraw their data from the system when the healthcare system is actually paid to collect it? To what extent can the individual say, it's my record, so I'm going to keep it in my health vault or whatever, and I'm going to sell it to whoever wants to buy it. I don't want you, the government, to do that for me. So I think we quickly get into kind of interesting debates about how to govern the data and how to manage it in a way that suits everybody, that respects privacy and confidentiality, but doesn't lock it up in mini silos so that we end up with not optimizing the value of it.
But how can we support a business model that encourages a marketplace in data and in knowledge?
Yeah, so I see you see this change going on. So I think Martin had it on his slide. He had the 3 different business models, and he had the innovation to the third one. So if you think The shift in all other industries has gone to a platform-based business model. And those companies that embrace a platform business model, which is how do we work together to attract people to the platform, and then how do we then work out how to make a commercial model after we've done that? And you drive attractors to the platform. So it could be open source software, it could be free data set definitions. How do you drive people to that platform? And you see there'll be some big players actually, collapsing over the period as we go over the next few years, because they're being educated by the market about this platform type business model. So, I mean, I think Martin mentioned about Nokia. There's a classic example of, big players will collapse. And, people have survived their life on a proprietary licensing model that I charge you a massive capital purchase and I charge you through, through the nose for money going forward. Just really isn't the model that's going to survive. But they're in this changeover period where there are still companies, that's all they've got to make their money on, so that's all they're going to sell you. But if you look at things and where healthcare doesn't help itself, I talked about it in our session around the procurement side. So healthcare, it's only recommended you procure through the digital cloud framework, where all other government offices you're mandated to first procure to that. That absolutely drives you to the platform model, which will drive your costs down and stop you having proprietary software licensing. So there's some interesting changes and dynamics in the market. I'll give you an example. My old company in IBM, who would have been great competitors, created companies together around open source software, around Pivotal. So I see IBM and other companies moving to that model. I could name other ones who I don't see, and they just won't be in existence. It won't be the healthcare model that puts them out of existence. It will be the other customers that put them out, because industries like finance and retail are adapting these models quicker, and then they won't be able to survive there. So on the procurer side of healthcare, they need to wake up and start procuring in a different methodology than they do at the moment. If they're still willing to go out there and make big capital purchases, then really they're in the wrong open source model. They're not looking at that.
Perhaps as a follow-up, so I guess we need these new business models, but I guess in addition to that, there's also a responsibility with us, educators, and also the educators in primary and secondary schools, to help people better understand what it means to share your data and which different options exist. I guess we're now in a situation that is happening all the time, but most people don't have a clue what that really means. So it's also very difficult to engage with them and build up a partnership of trust in doing that, because they don't know what it means and what the different flavors or options are. They don't understand. So I guess that's another responsibility to educate people in that.
Let me give you a great example in the research business model. So anybody going for Horizon 2020 funding at the moment out there? Yeah, you're probably all going. A couple of simple changes they made in that funding. You must have 3 European countries working together, and you must have a commercialization strategy at the back end of that funding. Immediately, well, no one country is going to save that data. Opens up a platform business model, because somebody has to offer a service for you to put that data in. So I even see that the model of business model research has been driven into a different change model. Sorry, Chris.
It's okay. I know that you didn't want to talk about sort of like the interoperability, but I do believe that there's a case in regards to upfront organisations and healthcare need to say, if you don't provide APIs from day one, we're not going to be interested in your systems. And I know it's sort of like evangelizing, but the thing is, the problems that causes if you don't have that mandate. So, for instance, you can connect up the most beautiful system, but if you don't have any API, it's just another silo, and you need to do a lot of development work in-house. There's resource implications. Whereas actually, if that was done up front as part of the negotiation, you would have a much better platform as a whole NHS. It's my belief.
Yeah. Brendan, I think you've mentioned what would be game-changing in this space for breaking down the silos, and that is the learning health system.
Yeah.
If your customer says that my population served by this health system require the data to be used so that the services get better and learn from how they are used, then that interoperability is implicit.
Yes.
It's part of the requirement. Different silos, different production lines that really don't touch each other at the moment. So commissioning, audit, research, service evaluation uses, of the same data that do not learn from one another, that waste taxpayers' money because they don't borrow their data processing from one another, will have to come together for a system to learn. And even within the silos, there are sub-silos that represent cultures. Only a few weeks ago, I came across two companies providing audit databases, one to the cardiac surgeons and one to the cardiologists. And they were adjusting for renal function in their outcome models, their case mix adjusted outcome models, differently. If it was very clear to all of those players, if these were truly interoperable systems, trying to do similar things, trying to predict similar things, that this is what people have touched over here, like the Amazon experience. You've got this in your shopping basket, other people who had that also had this. It's not beyond the wit of man to take some of those big data technologies, tools, and business models and use some of them to propel us towards these learning health systems.
So I think what I'm hearing from the panel is that the answer to all the issues around creating silos, be they data silos, physical silos, or commercial business silos, is if you emphasize learning health cycles, you automatically place interoperability as being fundamental in the reuse of data and knowledge and regeneration of things. So, I mean, I set that out now to the audience for comments, questions. There's a premise for you. Don't think big data, but think learning cycles and a learning health system. What do you think? Yes, gentleman here at the front. The microphone, please. Yeah? Stick your hand right up so I can see you. Thank you.
Hello, my name is Yemi Ojakule from Swansea University. We're talking about big data sharing, usage, and basically we've not really talked about educating the public who are basically the owners of the information. Actually, my question is, in healthcare, I know there's always problem about who owns information, who to give it to, who can use it. Is it the confidentiality issue and the privacy issue, or the confidentiality and privacy advocates?
Okay.
Don't we think it's going too far? Sorry for anybody that take it personal. Because every other sector of the economy, you don't know who has what about you. For example, the financial institution, if you owe a bank any money, you know basically there's a company at your door asking for the money, even though you don't owe them any money. So basically, so my question is the confidentiality advocacy, is it going overboard, which is kind of like hindering the right usage of big data to improve healthcare?
Okay. Well, I knew we would come eventually to this really thorny topic of public trust, openness versus privacy. Maybe that's a good point to pick it up. I mean, we still have all the fallout from care.data. How do we do this? How do we establish trust in a learning health system or a big data system so that people can feel confident their data is being used appropriately?
I think the key is communication. In regards to, you need to get all the stakeholders together, and the patient or the citizen is a key stakeholder within this. And I think that sort of like would address some of your issues in regards to, okay, if they are a true partner and they are part of setting up this bigger data set and sort of like, you know, what systems collect what, we have some way forward. So, for instance, in my county, I work in Hampshire, so we have a Hampshire Health record, whereby all the organisations sort of like feed information into for the greater good. So, if I'm a person in Basingstoke, but if I was admitted in Southampton, which is 60 miles down the road, they would have some sort of information about me if I couldn't tell them. But the thing is, there's a huge communication drive via the GPs in regards to making sure that the patients understand that and they're part of that. And if you want to opt out, you can, and and that's fine. And if you want to switch back in, that's easy to do as well. And I think that's at a localized level, but I think we can scale that up much further. And I think that will address some of these myths, because as you were saying, it was a PR disaster in regards to looking at the patients or the National Patient Care Summary record, because I got my statement in the same mail when it said, okay, here's your nearest Pizza Hut. Oh, by the way, care.com is coming, and would you like to adhere to it? And obviously that wasn't the way to do it.
I think of three different T's here, of trust, transparency, and traction. Many of our debates quite rightly focus around public concerns and sensitivities around misuses of health data. But they're not held in a transparent discussion about what is not being done with the data. The harm that could be avoided if the signals in the data that are there now were surfaced. And whenever we take this to our own public and patient involvement groups, they get quite annoyed that those signals aren't being surfaced because the data are too difficult to process for those purposes. That takes me to traction. If we're saying that the velocity of data that Owen alluded to is a really important part of the future, then we're looking at a move towards a new conversation of healthcare between patient, clinician, and information system, where the patient is a much more active co-producer of that health record. And we really want the most reliable signal coming in that the clinician cannot enter. I think we're moving into a different conversation around this sort of transparency that will engender trust for that whole community to benefit from the learning health system.
Absolutely agree. I think the issue of trust and transparency and good exemplars of how information is being used. I was part of a discussion group in London a couple of months ago. The Health Research Authority have been running some public consultations around release of data and governance. So we had some members of the public, and what was quite interesting was if you asked them the question, is it a good idea if anonymized data is used for research? Would you like your data to be used for research? Practically everybody said yes. And then there was a discussion around what actually happens with your data. And 80% of people in the room didn't know that when they rang up the doctor's surgery, the receptionist would bring their record up on the computer and could see their medical record. And this led to a real pullback from things. So I think there are a lot of potential issues around transparency, but we do have to engage with that because there are huge myths in both directions.
So let me just move the conversation on trust to a completely different point. Okay. Everybody puts trust up as a negative, okay, and something to stop doing things. So if you start thinking, as a businessman, I look at things and say, how can I turn trust into being a value creator and attractor? So if you look at this on the global scale, how trust could be an attractor for UK PLC, we've got some very interesting things going for us as the UK. So one, we have a very differentiated, we don't have a constitution, which doesn't hold us back. There are only 3 countries in the world that actually don't have a constitution. We have a very flexible and fast legal system. We've set the agenda around process and methodology, whether it's from IT, ITIL, right the way through to medical standards. We have set the agenda. So as reputation globally, we have a fantastic reputation about being a trusted nation. Then when you look at us geographically, you look at us, we look like a data hub on the world map. We sit in a fantastic time zone between, say, China and America. And this is work I was doing with the Irish government before I left living in Ireland, is how can we turn the UK, or in the time there it was Ireland, into an attractor of other people's data because we have a fantastic reputation about trust. Yes, we have a lot of nuances, but how do we turn that, and how do we say, actually, it's a really good thing, we're really good at this, and this is what we can do. And we're working with GEL at the moment, Genomics England, around, and they've taken some of the ideas around this idea of data embassies. You know, we have an embassy car, you have an embassy bag, you have an embassy you go to. Why don't I just zone my land to be an embassy of your country, and you would come and put your data here? Because as a country, we're quite trusted. We don't realise this on the global stage. We have a brilliant reputation. So why aren't we leveraging that reputation to actually attract other countries to us? Now, would you, I mean, people offshored their app development to India, to China. Would you now start putting your healthcare data India, China? Probably not, but would you put it in the UK? Probably you would. And what comes with that data is the data scientists' jobs to work around it and many other things. So I think you have to start looking at this issue of trust, not just as a stick to beat people with, rightly so, yes, but also look at it on how can this be a creator of jobs and a creator of value for us as a country. And there's some brilliant stuff going on with the FARs around data governance and data safe havens, yeah? That message globally, when you've got the Americans with the Patriots Act saying, well, I'm not going to put any data in an American system, is just some fabulous stuff we could leverage. So I'd urge you to sort of think differently, because then people see us and they see us portraying ourselves as a negative country, and actually we've got some really good things going for us.
I want to get out to the audience now for questions. The lady down there had a hand up. Sorry, could I have the microphone?
The question of trust.
Yeah.
If I put all my banking records online, which I do, and then I'm a bit worried about what's happening, I can sign up to Experian or another commercial provider and go and have a look at my credit record. If I let people take my health data, I've got no way of knowing what's actually being shared with who and what decisions are being made on it. I really can't understand why in this country we don't have a big blue button campaign, because if everybody else can have the patient's data, why can't the patient also have the patient's data? It's okay talking about trust and monetarising things and looking at how we can do all the myriad of things we can do, but actually if we don't bring the patient along with everything we want to do and talk about what actually is worrying the patient and what it will take to reassure the patient, then I actually tweeted just now, we've got a mindset problem. Is big data something there should be universal buy-in to because it's wonderful? Or is the counter mentality that 1984 was a warning, not an instruction book? And until we really grapple with that, and the fact that papers like the Daily Mail in England are very anti a lot of this, and until we get a public movement behind us to say, this is good, we should be doing it, we're always fighting the battle. And I think we've left the patient behind, and I think we're underestimating the fact that if we start there, we could unlock a lot of gates.
A quick comment, so Ian, I know this is close to him. Chris, I'd like to hear from you as well.
This panel has already said we don't like the phrase big data. We don't like the attention on data, because it takes the attention off what's really good for patients and communities, which is what should be done with the data, and what is being done in very small measure at the moment with the data to turn them into public benefit. To answer your question about what is being done with your data, I fully echo your sentiment. I would really like to know that my records and my loved ones' records are being put to good use, that knowledge is being generated. I'd like some little signal that I could choose to dig into if that green light comes on, said, someone stepped on your record and done something with your record to build this learning health system that is part of your community. If we want to have that Amazon-like experience where different data processes learn from one another, you can have a byproduct that feeds back to patients of what's done with their data.
I completely agree with that.
I completely agree with all the points that you make, and I think this is where the shift has to happen in regards to, we talk about patient activation, yeah? I mean, you know the concept whereby the patient starts to sort of like activate services and knows there's something wrong and starts a journey. But the thing is, as you also say, we talk about it, but actually what we need to do is we need to start to do the action. So we need to get these groups, and we need to get those groups more formalized. At the moment, it's still, I mean, unless people in the audience have got different experience, it's still sort of like, okay, we're seeking out certain, I don't know, patient representation groups, whereas actually what we need to talk about is it needs to be embedded. So it shouldn't be an option. That should always be the case. And again, going back to that gentleman's question, you know, it's the person, the citizen, the patient, whatever you want to call the public, they are the key stakeholder. They have equal stakeholding premises on healthcare debates and big data.
Yeah, well, I think that's a very good point for us to end our session. Thanks all the panel for your contribution. Thank you very much to the audience. Thank you.